Okay. Welcome everyone to the One Payer States discussion on the State-Based Universal Healthcare Act, what we shorthand call SBUCA, State-Based Universal Healthcare Act. And we're going to be discussing what that legislation is in brief, why we need it, and we'll have presentations from 3 of our states today. Dr. Steve Kemble will come forward after I'm done from Hawaii, and we'll have Charlie Swanson from Oregon, and then Consuelo Echevarria from Washington State to speak from the perspective of their organization work at the state level. Let me just open up by saying that that One Payer States is an organization that was founded back in 2009 for the explicit purpose of bringing together states to share information, best practices, build our morale. And for many years, we had phone conversations, sometimes once, twice a month, just to share notes and to keep each other boosted. So these were phone conversations. Fast forward till about 5 years ago, and One Payer States converted ourselves into a 501c4 organization for purposes of creating a more structured organization. And since that time, we've established work groups that focus on policy, communications, education and advocacy, communications I mentioned, and organization and development. And these work groups allow our all volunteer organization to be much more effective in doing the work that we do. And we invite everyone out there who's just becoming oriented to One Payer States, please join us at onepayerstates.org. It's one as in the number payer, P-A-Y-E-R, states, S-T-A-T-E-S.org, onepayerstates.org. We welcome your participation, your support. The organization was founded back in 2009 with the recognition, with the theory of change that so much of what's happened in American history has happened beginning at the local and state level. So many of the reforms in our society to end slavery, to get the vote for women, to end child labor laws, and the list goes on and on. The history of the progressive era, the New Deal, the Great Society, those national programs were all built on states experimenting and innovating. And we believe that the same way that occurred to make those national advances is most likely to occur here among states. So One Payer States is a consortium of 25 states, and you'll be listening again to 3 of them here. And so our purpose today is to orient you to the State-Based Universal Healthcare Act, also known as HR 6270, since it's been introduced already by Representative Ro Khanna, and the bill will soon be introduced by Ed Markey in the United States Senate for the first time. So we'll have a companion bill in the Senate introduced likely in the next week or 2. So as we fight for improved and expanded Medicare for All plan that works for all residents of our nation, we should look to the states to support state initiatives that model comprehensive guaranteed health care for all their residents. Time and again, states have served as the incubators for change, as I mentioned, at the national level, and we believe that this is the way that we're likely to move forward and create a national improved and expanded Medicare for all. So with the introduction of the Ro Khanna bill and soon the Ed Markey State-Based Universal Healthcare Act, this will create an amendment to the Affordable Care Act, Amendment 1335. It establishes a super waiver to allow states to develop their own plans, effective plans, more effective plans, with the use of these waivers, these financial and legal waivers. In fact, multiple states have already passed legislation to create programs for such a transition to unified financing systems. And these bills would greatly reduce the need for workarounds and thus substantially simplify the efforts in these states. And then finally, most specifically, what does SBUCA do, the State-Based Universal Healthcare Act? First, it allows states to integrate Medicare funds into a state plan. Second, SBUCA gives access to an ERISA waiver. That's the Employee Retirement Income Security Act, ERISA, waiver to reduce legal challenges to a state plan. Thirdly, SBUCA allows 2 or more states to apply for waivers together to create a regional plan. And fourth, SBUCA creates a broad Health and Human Services Secretary appointed independent assessment panel to review and recommend 1335 waiver applications. Again, that's reference to Section 1335 of what will be an amendment of Affordable Care Act. And I'd also just like to add that some 75 national, state, and local organizations have endorsed our work, and we are now circulating a national petition, so keep an eye out for that. We'll be circulating that during the conference. And yeah, at this point, I'd like to just thank everybody for the work that you do, and folks who have come into this meeting and take a few notes. And please join this effort. We really do need the help across the country. Now we're going to be hearing from 3 of our state leaders. First up will be Dr. Steve Kemble from Hawaii. Steve?
Hi. Hawaii is in a unique position because of our Prepaid Healthcare Act, which passed in 1974. It includes an employer mandate for all employees working 20 hours a week or more, and it requires that benefits and patient cost sharing for all plans must match the dominant plan, which was then and still is HMSA. So we've had rich benefits, no deductible, either 10 or 20% copays since 1974. ERISA passed right after the federal ERISA law passed right after, and we were given an exemption to allow us to implement our Prepaid Healthcare Act. But the exemption has a clause that says we lose the exemption if we change the Prepaid Healthcare Act. So we're locked into keeping it the way it is. The result has been the broadest coverage, the lowest patient cost sharing, the best benefit package, and among the lowest commercial insurance rates in the country, despite Hawaii's high cost of living. And our per capita Medicare costs were also lowest in the country prior to the ACA. Hawaii passed a law in 2009 to create the Hawaii Health Authority, which was supposed to be responsible for overall health planning in the state and to design a comprehensive health plan covering all residents of Hawaii. It was passed in 2009, didn't get implemented in 2011, and 9 members were appointed and approved by the Senate, including myself. However, the Affordable Care Act passed in 2011 also, and Hawaii's Democratic governor pivoted to implementing the ACA instead of the HHA. They took our funding, they threw us under the bus, and didn't implement anything we recommended. The HHA became inactive after 2013 due to lack of support, but the law remains on the books. A notable concern was that moving to a single-payer system would break the Prepaid Healthcare Act, and we might end up worse off if we were to implement something else. Our current governor and legislature, and also our current Hawaii Employer Union Health Benefits Trust Fund and the Medicaid Department, are all too beholden to HMSA and the health insurance lobby to risk making any big changes right now. And HMSA has also been all in on moving to value-based payment and capitating primary care doctors, with mixed and mostly negative results, but they don't want to hear that, and they seem to have the ear and line the pockets of the governor and the legislature. However, both of our U.S. senators and one of our 2 representatives in the House are single-payer supporters, but have no state-level backup right now. Sabuka wouldn't allow an alternative way to get around an ERISA waiver so that we could change the Prepaid Healthcare Act for the better without running afoul of the ERISA law, and do something that would clearly improve on the Prepaid Healthcare Act.
Excellent, Steve. Really good summary. Appreciate that. So next up is Charlie Swanson from Oregon. Charlie?
Oregon activists have been working towards a state single-payer system for quite a while. In 2002, activists successfully put a measure on the ballot, but it lost badly. Single-payer activism languished for a while, but in 2009, another group became active with a focus on national efforts. As Congress began considering major healthcare reform early in the Obama administration, it became clear that single-payer was not even going to be discussed. Some in the Oregon group figured it would be useful to write a state bill. By 2014, it became evident that it would be useful to get state support for single-payer effort. We got the state to fund an economic study. An early attempt at a task force to look at single-payer got watered down to a legislative work group, and then that got co-opted to look at incremental reforms. When Bernie ran in 2015 and 16, quite a few activists put effort back into the national single-payer movement, and it seemed hopeful. Many activists work on both state and federal levels and continue to do so. The Trump election changed the focus back to the state. After the work group failure, in the next session in 2019, we got a promise from the Senate Healthcare Committee Chair, Lori Monis Anderson, to hold a real hearing on our bill. We decided to rewrite the bill and make recommendations regarding a single payer system, to become a task force to do so. The bill was championed by Senator James Manning, and it passed. The task force got a delayed start and was further slowed by COVID. The work was not completed by the time their final report was due. Among the things that slowed their work were difficulties in figuring out how to handle ERISA. They got great information from ERISA experts Aaron Fuse-Brown and Elizabeth McCuskey, but it took considerable task force time and still left major uncertainties. The biggest issue with Medicare relates to provider reimbursement, a fundamental requirement for any equitable system, which was also explicit in the charge to the task force, is to remove any financial incentive for a healthcare practitioner to provide care to one patient rather than another. It is not obvious that current federal law provides a way for a state to do this for those who are eligible for Medicare. The task force recognized the problem with ERISA and Medicare and understood that SBUCA would solve these problems. While they were grappling with this, the 2021 reconciliation package was being considered, and Michael Luddy proposed to put SBUCA-like language in that package. The task force made an official request to Senator Wyden, who is chair of the Senate Finance Committee, to put forward such a proposal. Unfortunately, Senator Manchin made sure that not much good would be put in the reconciliation package. The task force proposed a governance board to continue the work towards a single payer system in Oregon. The 2023 legislature established and funded that governance board, which just started working in April and is tasked with making legislative recommendations by September 2026. The governance board is likely to get bogged down by ERISA and Medicare as well, unless they feel courageous enough to propose a decent system in spite of these potential issues. We expect that if there is clear and growing support in Congress for SBUCA, the governance board will be much more likely to exhibit the courage to propose an equitable universal system. They won't be so tempted to propose something that they can be pretty sure would withstand an ERISA challenge under current law, because it doesn't overtly impact self-insured corporations. They won't be so tempted to propose wraparound Medicare coverage that leaves low provider reimbursements for most Medicare eligible residents. One of the best ways to push for SBUCA is for states to propose a decent single-payer system that would be helped by the law. If SBUCA is not yet law by the time the state begins applying for waivers or starts implementing the system, corporate lawsuits against the state will incense many people, increasing public pressure on Congress to clearly and explicitly allow the state to help its residents. It's important to note that many members of Congress were state legislators first. That is true for 4 of our 8 representatives and senators from Oregon. A couple of them were supportive of state single-payer efforts as legislators, and it was easy to get them to support Representative Jayapal's Medicare for All bill in Congress. Those that understand the importance of SBUCA are much less likely to be fooled by some sort of a public option. SBUCA is a useful tool in many ways to move us towards the sort of equitable, affordable, universal national system that we need. Thank you.
Thank you, Charlie, for that excellent overview on what's happening in Oregon. And next up, we have Consuelo Echevarria. Consuelo?
Thank you very much. I'm a member of Healthcare for All Washington, a grassroots organization which for the last 30 years has been working for universal healthcare. In 2019, Washington State successfully funded the creation of the Universal Healthcare Working Group, which 3 years later led to the creation of our Universal Healthcare Commission. The 15-member commission is composed of elected representatives, state employees, and 6 members of the public. Along with the commission, we also have the Financial Technical Advisory Committee, which is composed of subject matter experts to guide and, well, I guess to guide the questions of the Universal Healthcare Commission. The purpose of the commission is a dual purpose. It's to address the immediate health needs of all Washingtonians, and it's also to prepare the state for the creation of a healthcare system through a unified financing system. SEBUCA makes it easier for Washington State to access federal funds to finance our own state-based healthcare system. Now, in Washington State, we do have something that's exciting that's happening. To lay the groundwork for a successful waiver application, Healthcare for All Washington, along with other healthcare advocates, has successfully proposed a study to consolidate the school employees and the public employees and non-Medicare eligible retirees into a single risk pool. This consolidation would cover about 500,000 enrollees in Washington State. The eventual consolidation of the state's health coverage would be an essential step in demonstrating to the federal government that Washington has the administrative capacity and expertise to incorporate Medicare and ERISA self-insurance plans into a unified payment system.
Consuelo, that was excellent. Thank you so much for your presentation, and also to Steve Kemble from Hawaii and to Charlie Swanson from Oregon. Just to remind folks that we're not just 3 states. You're hearing from 3 states today, but California is on the hunt, Minnesota, Maine, New York, Pennsylvania, Massachusetts. The list goes on and on and on. There are so many states that are doing so many great things. We're very excited about this opportunity to have presented to you this week during the Medicare for All conference hosted by Healthcare Now, our good friends at Healthcare Now. And I look forward to collaborating and moving together going forward. We invite you all to check out our work at onepayerstates.org, onepayerstates.org, and to support what we do, learn about what we do, and to join the fight to lift and elevate this legislation that Ro Khanna has introduced in the House, that Ed Markey is about to introduce in the Senate. Our intention is to get this legislation passed in the next Congress in 2025-26, and any number of states are going to cross the finish line in the next 4 to 5 years. So the matching of SEBUCA, the State-Based Universal Healthcare Act, and state universal healthcare systems is a match made in heaven. This, we believe, is going to get us pointed to a national Medicare for All system after having modeled what single payer can look like at the state level, similar to the way that Canada was able to get to national Medicare for All through a single province, that being the province of Saskatchewan. So thank you so much for joining us today, and please do stay in touch. We really believe that this is the path, the best way that we're going to be able to get this, the most likely way. So thank you again to Consuelo, to Steve, and to Charlie. And to Mike Huntington, who's been the engineer behind the scenes, and to all of our member organizations and the 75 groups that support and endorse our work. Everybody have a great week at the conference. Thank you.